Thank you very much and welcome everybody this evening. As Kelly said, I've been a urologist for quite a long time and I have a special interest in the management of bladder cancer, particularly through my appointment at St. Vincent's Hospital in Melbourne, but also in my private practice. I've had a relatively unique practice because being the second female urologist in Australia, I did have quite a lot more women come to see me with bladder cancer than perhaps other surgeons had. And in doing so, one of the things that I've been involved in, it's been the development of ileal neobladders for female patients. And that's been a great thing to develop. So what I wanted to do tonight is just to give my perspective about bladder cancer and about making the decision to go ahead with an orthotopic neobladder. What orthotopic basically means is we're creating a new bladder to attach it to the patient's urethra. And that's obviously quite different than an ileal conduit, which some of you may be more familiar with. So I wanted to go through how we decide as surgeons to advise patients about whether this would be appropriate. So it begins with the assessment of the bladder cancer. So when patients have bladder cancer, they generally present to us with blood in their urine. And when we see a bladder cancer at the time of the cystoscopy or on ultrasound or CT scan, what we want to determine is whether or not that bladder cancer is a superficial bladder cancer. In other words, it's occurring on the lining of the bladder, or whether it's gone deeper into the muscle layer of the bladder. And you can see from that diagram on the side there that we have a system that assists us at a pathological level with making decisions about what we need to do. The reason we become very concerned about patients with the muscle invasive bladder cancer is that's the layer in which the blood vessels and the lymphatics of the bladder exist. And therefore, once a cancer goes through into that level, it has the potential to spread elsewhere in the body or metastasize. And that's when we need to be much more radical in our treatment for it. So when it comes to cystectomy or removal of the bladder, the groups of patients that fit into that are those with that muscle invasion, those that have a condition called carcinoma in situ, which is a cancer of the lining of the bladder that is very aggressive and high grade, which hasn't responded to treatments into the bladder. And then those with more difficult, what we call superficial disease, where the whole bladder lining might be involved. And these are the groups that we then look at and say, well, what is going to be the best way to both remove their bladder? How many other organs are we going to need to take out? And then once we take out the bladder, how are we going to put everything from a urological point of view back together? One of the things that also comes into play for us is whether or not patients may need to have some associated chemotherapy prior to this major surgery. And the decision about that can sometimes depend on how the kidneys are working and whether or not we feel that the patient is up to chemotherapy. As many of you may be aware, chemotherapy for bladder cancer can really knock you around. It takes quite a bit of time to recover from it. But generally, when we do it prior to the surgery, we've only got a small window of about 4 to 6 weeks in which we need to then proceed to the surgery. And as you'll see with what I'm describing with it, it's a big job for both the patient and for the surgeon. And so we have to decide about that chemotherapy with a lot of important information. So what does a radical cystectomy really mean? Well, what it means is that we're taking out the entire bladder. In a man, we also take out some of the adjacent organs, which involves both the prostate and what are known as the seminal vesicles, which are little glands that sit behind the prostate. And in a woman, that involves also doing a hysterectomy if that hasn't been done before, and also potentially taking out the tubes and the ovaries. So as you can imagine, going through just removal of your prostate or removal of your uterus is a big job, but this involves 2 major surgeries. When we look at these, we sometimes think, do we really need to take out all of these organs? And is there a way for us to perhaps be more conservative with our surgery? And that depends a little bit on our imaging with things like CT scans and MRIs, and also on the cystoscopy, or the look inside the bladder with the scope. So we sort of judge each case individually, but generally we'd be looking at those extensive procedures where we're taking out the bulk of what is occurring in the front half of the pelvis in the patient, be that a man or a woman. So that part of the surgery can take us, you know, anywhere between sort of 2 to 3 hours to remove all of the organs that need to be removed. And we also take out the lymph nodes of the pelvis, which help us in determining what we call the stage of the cancer. So in other words, has the cancer spread from the bladder to those lymph nodes, even if it hasn't shown up on the CT scans or PET scans that have been done before the surgery. So when we start to put everything back together after the removal of the bladder, it's quite a big job, and we've already sort of 2 to 3 hours into the surgery. And so prior to it, what we've done is had a discussion about how is the best way to redirect the urine now that the bladder does not exist. And the majority of patients would undergo what is called an ileal conduit. Now, what that is implanting the ureters, which are the tubes that drain the kidneys, into a segment of the small bowel that is then attached to the skin. The reason that we use a piece of bowel is that we can't just bring those ureters directly to the skin, because the urine is very irritating to the skin. It's quite acidic and it can burn the skin. And if you just bring the ureters out, what will happen is that with time they will block off. So the ileal conduit is simply a piece of pipe that allows the passage of the urine up to the skin. It doesn't have any function as a reservoir, it's just a piece of piping. The alternative is, if appropriate, that we in fact make a new bladder, and that's what an orthotopic neobladder is. We use the bowel to fashion a new bladder that is then attached to the urethra, and those tubes, the ureters from the kidneys, are plugged into that neobladder. The middle one, which is called a continent cutaneous reservoir, is not a common operation for patients with bladder cancer. It's sometimes used to put to store urine, particularly in children or young adults who are born with abnormalities of their urinary tract. So usually we're making the decision between the ileal conduit and the neobladder, and a number of factors come into that decision making. So the first of those factors is what is known as the patient factors. So what we need to decide is perhaps to start with how long do we think the patient's going to be alive for? And it can be dependent, obviously, on the cancer, but it can certainly be dependent on other aspects of their life. Unfortunately, now in Australia, the biggest risk factor for getting bladder cancer is, in fact, advancing age. So when I first started urology, bladder cancer was pretty much a cancer of people who smoke cigarettes. But as the smoking rates in Australia have plummeted, and in fact, we're now, I think it's the second lowest smoking country in the developed world, we're now seeing age as a much bigger factor. So people are living longer. And what we think is happening is that there are substances in the urine that are what we call carcinogenic, and they sit in the bladder and cause changes in the lining of the bladder that can ultimately lead to bladder cancer. Now, bladder cancer sometimes happens in younger people, so it's not the only factor, but it's the most common factor. When it comes to doing a neobladder, one of the things that we also know is that many patients need to learn how to do what's called self-catheterization. which means that in order to assist the neobladder to empty, you need to put a catheter into that bladder, and you need to have good hand function. So dexterity is important. So for instance, if I see somebody who may have Parkinson's disease or a stroke or something that affects their hand function, I'll often have more concern about going ahead with a neobladder. We also use some of the cancer factors in deciding whether or not we think that the patient's outlook might be quite poor with regard to the cancer. Unfortunately, muscle invasive bladder cancer still only has a 5-year survival in the order of about 60%. So it means that 40% of the patients we see have a poor outcome with regard to that. And that has an important, it's an important thing to take into consideration when we're deciding to go ahead with a very big reconstructive operation. If patients have got issues with their liver function or their kidney function or their heart function, or they're still smoking, all of these things have some impact on whether we think this is the right way to go. From a surgical perspective, if our patients have had previous radiation to their abdomen or pelvis, or if they've had a lot of previous surgery, then sometimes this isn't the best way to go, because taking down things like adhesions in the abdomen adds perhaps another hour to a surgery that might already be looking at being a 6 to 8 hour procedure. So before we make that decision about what's going to happen, once a patient's booked in to have their bladder removed, we've already decided which is the best way to reconstruct the urinary tract. Now, from a
Anita, one question. Is there an age cutoff for doing this radical cystectomy and neobladders?
Yeah, look, I've tended to go with under 70 in my practice when I first started. Having said that, probably in the last 2 to 3 years, there's been a few people in their early 70s who've decided to go ahead with the neobladder. I think that sometimes that can also have some effects with regard to things like pelvic floor function, and especially other comorbidities. So the majority of people, once we get to sort of 75, are on a few medications and got a few other health issues where the neobladder may not be the best way to go. So I would say 70 is probably my cutoff. I think in the literature, it's pretty much 80 is given as the cutoff, but it would be unusual, I think, for somebody to be done in the latter half of their 70s.
Thanks.
Some other factors that, that might come into play are things like sexual function and body image. Certainly for younger patients, they will often say to me, I don't want to have a bag. And that can be confronting if it's not appropriate from a cancer point of view. It is a more technically difficult operation from a surgical perspective. And as I said, it is longer. So we have a bit of a discussion about all of that before we then go ahead. And one of the things that increasingly has been very helpful for me as a surgeon, and certainly within a group like yourselves, is the input from other patients. It's all very well for me to say, this is what having an ileal neobladder is going to be like, but I don't have one. And I think that the experience of others and the ability of others to help not only with what it's like, but even with the nuances of what they've found with their neobladder can be of great assistance. And I've found that collectively, my group of patients who have neobladders are very supportive of each other and very happy to share their ideas, as are my patients with ileal conduits. I've had a couple of patients with muscle invasive bladder cancer who've said to me, I'd prefer to die than have that bag. And, you know, I've had the assistance of some of my patients to actually convince them to go ahead with it, even to the point where one of my wonderful patients who used to work in health is very happy to take off her clothes and show people her ileal conduit, and show them how she changes a bag and what a night bag is and that sort of thing. So this has been a really great part, I think, of the bladder cancer community supporting each other, because, I have to say, it's probably one of the worst surgeries to have from the point of view of the impact on your body, the recovery phase, and also just the pure physiological changes that can happen in your body when you take out the front part of the pelvis. From our point of view, also, there are times where I have to unfortunately say to patients, an ileal neobladder is not going to be an option. And that's particularly if the cancer is very close to the neck of the bladder, or if it's gone in through the prostate or into the urethra. And in those situations, what can happen is that we need to remove the urethra as part of the cancer operation. And in that case, obviously, we don't have anything to attach the neobladder to. And so in those, that can be part of the initial assessment when we do the diagnosis of the bladder cancer, is that we're often looking at some of these other cancer aspects when it comes to making that decision. So when I decide to go ahead with ileal neobladder, I do one known as a Studer ileal neobladder. There are a number of descriptions of different types of neobladders, all of which were developed in Europe. The reason I do a Studer one is because this is the man from whom I learned ileal neobladder. He is a Swiss surgeon who's now retired, who specialised in the development of this operation, but was also had enormous experience in the management of bladder cancer, and was a man, or a surgeon to whom many people from various parts of Europe and the US went to have their surgery with him in Switzerland. And so the principle of his operation is to take a piece of bowel and effectively build a new bladder. So what happens is, as I said, we've started off the surgery and taken out the bladder, all of the organs and the lymph nodes, and then we have to get to the reconstruction. Now, I have increasingly in recent years done this with another urologist. We found that at the end of the neobladders, we as surgeons were feeling like we'd been hit by a train, and so that it was better to share the load. And so what I tend to do is, if the patient is my patient, I do the cancer part of the procedure, and then I step out and have a quick coffee and something to eat, and usually a bit of a wee, and then the other surgeon starts the neobladder reconstruction, and then I come in and do some of that whilst he goes out and has a break. So we try and support each other through this, because when we're making this neobladder, what we need to do is to take about 60 centimetres of the bowel and to reconstruct it into a pouch, which takes a lot of suturing. So there's a lot of stitching that goes on when we're making this new neobladder, because we're basically taking a tube and making it into a balloon. We've then got to attach that balloon to the urethra, and then we've got to join both of the ureters to the what we call the proximal end, or the proximal limb of the neobladder. And so all up, that reconstruction can take us another 2 to 3 hours. And look, whilst we try our best when we're surgeons to stay reasonably physically fit and be able to do these big operations, they do take a bit of a toll on us. And so, as I said, that's one of the reasons that we've started to do this as a joint procedure. Because the reconstruction, putting this back together well and doing this as best as you possibly can, then will minimise what could potentially go wrong going down into the future. And a few things can go wrong. So that's why we want to make sure that we're at our best when we're joining all of this back together. And so you can, sorry.
No, go on, Anine.
No, Kelly, you ask.
The question has come in, what sort of support do you give to the neobladder? Is it just sort of lying loosely in the pelvis, or do you attach it to anything?
Yeah, so what we do now is one of the things that Studer found in all of the work that he did in the laboratory was that it was really important for the urethra to be straight. So if you think about your neobladder, it is, as you say, kind of floating in the pelvis there, Kelly. And what we want to do is make sure that it does have some support so that that urethra stays nice and straight. Because if the neobladder is full and it falls down onto the urethra and kinks it, you then can't pass urine. And so what we're finding now with learning that sort of thing is that the need for self-catheterization has slowly gone down. So what I do is I support it to the anterior abdominal wall. In a woman, if I can, I also leave the vagina and sit it on the vaginal wall if there's no invasion of cancer into that plane. And so that gives it really good support. So we're keeping it in a nice straight line. And that's a very good question, because that's probably one of the biggest discoveries when Neobladder first started, about the ability to support it and to make sure that urethra is nice and straight. And so we, as I said, we're kind of suturing away and suturing away. And then the other big thing is attaching the ureters to the neobladder. So that the ureters are very flimsy structures. When I get to the big hospital in the sky who designed us, my first question is, the ureter, what were you thinking? Because it is an organ that is regularly injured in different forms of surgery. And it is a difficult organ to operate on because it's about 3 millimeters wide and you can see through it. So it's like stitching tissue paper almost back together. And it has a very flimsy blood supply. So if you don't maintain the blood supply and if you don't stitch it well, what will happen is that where the ureter joins onto the neobladder, you will get scar form, and then that causes back pressure and damage to the kidney. So again, that's the last part of the operation, and we're 6 hours in. So we take it in turns to do the ureters as well. And we use what are called stents that are put in under that joint, which go into your neobladder and up to the kidneys, which are like a plastic tubing, and they help in that period of time that that joint is healing up to prevent the scar from coming.
My question, Anita, for the body designers or the operation gods, whatever you call it, why did they put the prostate around the urethra is something I would like to know as well.
Oh, yeah, I've got that. Plus I've got, why did the baby come out there?
Yeah, yes. Not to sidetrack, there's another question, maybe at this point it's a good idea to ask. How do we contrast this neobladder positioning with where you position the ileal conduit and attachment of ureters there?
Yeah, so the ureters are attached in a relatively similar way. They are a bit higher up in a neobladder. The conduit tends to come out onto the right side of the abdomen, and we need all of the ureteric length that we can get in that situation to swing particularly the left ureter across to that right side. With the neobladder, as you can see there, we've sort of got that what's called the proximal limb is sitting up a little bit higher, and it's internal and it doesn't have to go through the abdominal wall. And so therefore the ureters can be a little bit higher up and a little bit shorter if needed. But essentially they're sitting up probably just below the level of the umbilicus at that stage. And the reason I do the Studer with that proximal limb is that if anything happens to the neobladder, particularly if there is a cancer recurrence in the pelvis, I can change that proximal limb to become an ileal conduit if I need to. So you can cut that off at the top of the neobladder and bring that out to the skin. Now, thankfully, I haven't ever had to do that in any of my neobladders, but I have had to do it in a couple of patients who had neobladders with other surgeons who've needed to have radiation to their pelvis after the cancer has come back there. We try as best as we can to minimize the risk of that with the chemotherapy and, as I said, with the patient selection, but we can't always be 100% certain it won't come back. So once we've finished this surgery, so then what happens? So in the post-operative period, I say to all of the patients, be prepared for the first week to be a bit of a nightmare, and certainly for it to take at least 4 to 6 weeks to feel like you've recovered from this surgery to any extent, and up to 6 months before you feel really as if, you know, this you've recovered from this, because it's a big, long surgery. I still do them through open surgery, and I'll come to that with robotics going forward, but it's a big wound. You have a drain tube in that drains any of the excess fluid in the abdomen. As I said, there are the stents going up to the kidneys, which are often brought out through the abdominal wall, and a catheter is placed as well that needs to be flushed pretty regularly. And all of that neobladder and that joining of things back together can take anywhere between sort of 2 to 4 weeks to heal up. And so in that time, you've got all of these tubes inside. But the biggest challenge to anyone having a neobladder, and really for anyone having bladder cancer, is the recovery of the small bowel. So the small bowel doesn't like surgeons to put their hands on it. And so it goes into a shocked state, and you get what is known as an ileus. So what that means is that the bowel just turns off and it won't work. And so patients often find themselves very distended because their bowel fills up with gas and with fluids, and nothing is moving in the direction that you want it to. And it's very uncomfortable, because a couple of the things that exacerbate the ileus are certainly the painkillers that are required after the surgery. But as your bowel starts to distend and put pressure on the abdominal wall and the wound, you need more painkiller. And so you get into a bit of a vicious cycle with regard to this. So that's the real challenge for all of us. And it's the patience that is required. And sometimes, you know, I go and I think, oh goodness, come on, bowel, come, keep going. And we encourage it, and we do a few things and give a few medications, but sometimes it is just time. And that can be very frustrating. And during that time, a lot of fluid and protein from the tissues is being lost with that big raw surface that we've created by taking out the bladder and the adjacent organs, and also from these dilated loops of bowel. They often lose a lot of fluid as well. And so in that time, it's important that, you know, patients are given a lot of fluid rehydration. And for those who've had chemotherapy, they often have pretty ordinary veins, and that can be quite challenging when it comes to accessing veins and keeping going with intravenous fluids. So the first week is a big challenge. The second week, things usually start to turn back on, which is, you know, is good. And then usually by that third week, we're starting to get a neobladder that is starting to heal. Those big suture lines that I showed you are starting to become waterproof. We sometimes do an X-ray called a cystogram before we take out catheters or anything like that, to make sure that it's all healed before the neobladder then starts to function as a bladder.
Would you say that the neobladder post-op recovery is longer or more complex than an ileal conduit?
Yes, definitely. I think from a metabolic point of view, because there is much more raw surface. I think the ileus tends to be longer generally, and that just the impact on that small bowel function is very significant. In an ileal conduit, we would usually use about somewhere between 15 and 20 centimetres of the ileum, whereas here, as I said, we're using 60 centimetres. So the impact on small bowel function is very significant. And also, I think the duration of the surgery is a factor as well. You know, the exposure of that small bowel to the air, as people talk about, is a big consideration. So in that period of time afterwards, a few things can start to happen. Look, when we do this big cancer surgery, there's always the chance of bleeding. The big blood vessels of the pelvis, which are going down towards the legs, are pretty close to the bladder. And we sometimes do get bleeding at the time of the surgery, and sometimes even after the surgery, there can be issues with that. Because we are close to those big blood vessels, there's always a risk of patients developing blood clots in their legs. And many of you might have had compression stockings and compression devices, as well as blood thinning injections in that post-operative course that can go on sometimes for up to a month if we think that the risk is significant, because if a clot forms in the pelvis, the pelvic veins, the risk is it can then break off and go to the lungs and cause what's called a pulmonary embolus. And so we're very aware of that as urologists, and we spend a lot of time trying to make sure that people are up and about and moving before any of those things are removed. It's possible to get infection. Once you start putting bowel into the urinary tract, there's an increased risk of getting infection into the urinary tract. Generally, our urine is pretty sterile and bacteria don't live in the urinary tract in any big numbers, but in the bowel they obviously do, and they can get into the neobladder and cause urinary tract infection, which can spread up to the kidneys. And obviously chest infection can be an issue when you're in bed for a prolonged period of time. You can get a leak from the join of the small bowel where we've taken out that 60 centimetres. We've got to join everything back together. That's another lot of stitching I forgot to mention. And we talked about that earlier. So the bowel can cause us some real issues, as can what are called the electrolyte imbalances. So one of the functions of the bowel, particularly the small bowel, is to balance things like the acidity of our blood, and some of the salts in our blood. And once we take out a big portion of that and start putting urine into that, a lot of things can start to get a bit imbalanced. So in that period of time after the surgery, a lot of blood tests are done to check up on how everything is going. So as I said, that first week or two after this surgery is a big deal. It involves a lot of needles, and it is painful, and it does take a big recovery. But the advantage is that, we've got this neobladder that once it starts to work is much more comparable to the normal bladder than an ileal conduit is. Let me get to that next one. So once you get to that phase of the neobladder starting to work, one of the things that can sometimes be a factor is the production of mucus by the small bowel. So our small bowels produce this slimy stuff called mucus to help move things along as our bowel contracts in one direction. And when we make a neobladder, that mucus production continues. It sometimes with time decreases in amount, but there'll always be some of it. And it can cause things like blockages to the passage of the urine if it becomes a bit claggy. It can certainly increase the risk of infection in that situation. And it can sometimes make it difficult, if you're dependent on a catheter, putting it into your bladder for that catheter to drain well if it clags up with the mucus. Some patients find that cranberry juice reduces the mucus production. That's an old-fashioned thing that we've used for many years in urology. And in fact, when I first started urology in the 1980s, cranberry was not available in Australia in any big numbers. It wasn't something that was able to be imported from the US, which is where the majority of it is grown. And it was only available at the David Jones basement. And so we'd send these poor people off who'd had their bladders removed down to the David Jones basement to buy these incredibly expensive bottles of cranberry juice. But it did help with the mucus production. And now, as you know, you can get cranberry in tablet form and the juice form, and many patients also quite enjoy taking the fresh cranberries, but it does seem to be quite helpful in that situation. The other big thing with the neobladder is what is known as continence. So what we want, if possible, is for the neobladder to be able to hold urine and for the decision about passing that urine to be up to the patient. Now, initially, the pelvic floor muscles can be quite weak. We've removed a lot of the surrounding structures of the pelvic floor, but in doing these big pelvic operations, we also can sometimes damage the nerves to the pelvic floor. And those things can then result in that muscle weakness, which results in what's known as stress incontinence. And strengthening the pelvic floor prior to surgery can sometimes help in that situation. The other thing is that when we first take the catheters out of the neobladder, which has been empty for the period of time where the catheters have been draining, it's quite a small capacity bladder, and it takes a bit of time for it to build up its volume. So that usually at the beginning, it will only hold maybe 100, 150 mils and then release. And in that situation, leakage can occur. In rare situations, we sometimes unfortunately get connections between all those stitches in the neobladder and stitches that might be in the vagina, particularly in women. And that can cause what's known as a fistula, which is a connection between the two where the urine can leak. So in the early part of neobladder time, continence is often a big issue. And so what we need to do is to just be patient. As I said, the capacity of the neobladder will build up. It's important to try and keep the neobladder empty. And in that early phase, when it's not very full, it can actually be quite hard to empty it. You rely a bit on using the abdominal muscles to push out the urine, because unlike the bladder, which has beautiful interlacing muscles that contract and empty, the neobladder is kind of a little bit more lazy and doesn't contract as well. And so you need to push the urine out. And the smaller the volume, the harder that can be. And in that situation, that's often when you need to learn to use a catheter to help assist with that emptying. If you leave a whole lot of urine behind, there's a few things that can happen. The most scary of which is that the neobladder can rupture. Thankfully, again, I've never seen that happen, but we have had a couple of cases of that up at St. Vincent's Public. But the other things that can happen is that infection can occur, and you can also get an imbalance metabolically, and you can develop some problems with kidney stones. One of the things that increasingly patients are doing now is using bladder scanners or portable ultrasound to check on the bladder emptying. And I think that's a really good idea, because it's quite a new thing to learn how to empty your neobladder. It's not the same as your bladder, and that takes quite a lot of time. With regard to that first couple of weeks, what usually happens is you need to pass urine every 1 to 2 hours, both through the day and through the night. And it's quite important to be aware of the fact that most patients will leak some urine in the nighttime in that early phase. So having pads on and learning to use condom drainage can be important in that early phase. The other thing is that the urine comes into the neobladder, and unlike our bladder, which has a beautiful waterproof lining so we don't absorb that fluid, some of it goes back into your circulation and can cause some issues with regard to your metabolic issues and the balance of salts in the body. So that first period of time, again, is a bit challenging, and many people are very tired after this very big surgery and long hospital stay, and then you're getting woken up to go to the toilet every couple of hours. Not a great deal of fun in that early phase, but it does build up. These are just some of the quoted long-term complications that can happen with a neobladder. Incontinence is about 10% of people who leak both day and night, and about a quarter of people will continue to get some leakage at night. As I talked about, the scarring that can happen when we join the ureters onto the bowel happens about 15% of the time, and about 30, probably closer to 50% of people who have a neobladder for more than 5 years would have to assist its emptying in some capacity with a catheter. And then there are those infections, metabolic issues, and that sort of thing that I talked about. The advances that are coming in this area of surgery are great. One of the things that we know a lot more about is what is known as the nerve innervation of this part of our body. And we're trying to develop what are called nerve sparing techniques so that sexual function and continence are much better. We also appreciate now that we need to be very ginger about destroying the blood vessels of the pelvic floor, which are important with its function. Much of the improvement after the surgery is through what's known as the ERAS program, which is trying to get that bowel going sooner with earlier nutrition and using some medications to try and help. Probably the biggest advancement is coming with robotic surgery, which helps us to assist with doing this through keyhole surgery. At the moment, it still has some issues because the stitching is tough and also the operative time is longer. So you have to get patients who can take surgery for up to 10 to 12 hours to have it done through a robotic approach. So we have to, again, be very selective. And as I said, I think the use of the scanners and the portable ultrasounds to check on the emptying has been a big advance, certainly in my own practice. So the long-term follow-up, obviously we have to follow people from a cancer perspective. We have to follow people with regard to their neobladder function. We look at their kidney function and how their blood tests are going, and particularly with regard to things like their B12 and their salt levels. And we check the kidneys to make sure that they're draining. So that's sort of neobladder in a nutshell. I'm very happy to answer any questions, either of your own experiences or particular questions you've got about that technique.
Anita, that was excellent. Honestly, this is the first talk we've ever had purely dedicated to neobladders, and to have a specialist like yourself, you know, I think you're like Australian gold. I feel like you belong in a hall of fame somewhere, especially being the second female urologist in the country. We're very privileged to have had your talk tonight, and it's been very interesting. We also have quite a few patients of yours that attend our group, and you know, they always give some very good testimonials about your service and the aftercare they receive, and the success of their surgery. So thank you. And within the chats, you've also looked after someone who had a conduit as well, back in 2019 when their Dr. Ming was away.
Yes.
They thank you. I don't know if you remember the patient. It's 4
Yes.
years ago.
One of the things, Kelly, is I've kind of got a memory like an elephant, so I do remember pretty much all of the cystectomies I've ever done for someone.
Oh, amazing. Okay, well, yeah, there we go. So they thank you. There are some questions though related to your talk and about neobladders. Comparing a neobladder to an ileal conduit. Oh, sorry, where was that question? Is there any difference in longevity of the ileal conduit versus a neobladder?
Yeah, I think that's a great question, because when I first learnt urology, we were told that the ileal conduit had a lifespan somewhere between 10 and 20 years, and that most patients, particularly by the 15-year mark, would need a new one. Now, I think we've kind of proven that wrong. So many patients with ileal conduits go much longer than that. My oldest patient, not that I operated on, but who had a conduit as a child, still has a functioning conduit is 53 years old. So you can have an ileal conduit for a long time. The thing that can go wrong with regard to urine in the bowel is that the bowel can sometimes lose what's known as its compliance or stretchability. And in that situation, the ileal conduit can then become not a good pipe, but more like a concrete pipe. And in that situation, we may need to replace it because it can then put back pressure onto the kidneys. With the neobladders, our oldest neobladder patient at St. Vincent's has now had his for 30 years and still going well. And we're keeping a close eye on things. He has become catheter dependent though, so it doesn't contract anymore. So I think that's the other thing, is that probably the neobladder does lose some of its ability to empty. But comparing the two, they both have a lifespan, but it's probably longer than we thought initially.
So if the neobladder did pack up, would you make another neobladder, or would you then go to ileal conduit?
Look, we'd probably go to ileal conduit and use that proximal limb. The reason being that once we have to get into a person losing 120 centimetres of bowel, we start getting towards what's called the jejunum, which is the other part of the small bowel, and the metabolic consequences are much greater in that situation.
That's great. Another question, how many neobladders are done a year? It's not something that's spoken about. Like we said earlier, not many urologists do them, or they shy away from them. Or they, so sort of, do we know the numbers? Or? Well, look,
in the absolute numbers, I don't have that information, but I would say in my practice, it's probably in the order of about 10% of the patients would have a neobladder. I'm increasingly seeing patients with invasive bladder cancer who are much older, and it's a very difficult decision about whether to treat people in those age groups. My oldest lady I did was 90, and she really wanted to have her bladder out because she was bleeding heavily and very symptomatic. We would probably generally, for patients over the age of 85, recommend they have chemotherapy and radiotherapy rather than surgery. But it's a very individual decision, because, you know, there are 85-year-olds and then there are 85-year-olds. You know, my own mother's 85 and hasn't gone grey yet and doesn't have anything wrong with her. And if she got bladder cancer, she'd probably have surgery, you know, because she's up to it. But there are many, you know, people in that age group who have other illnesses that prevent us from doing that.
We have another patient that's has bladder cancer, non-muscle invasive at the bladder neck since June 2020, and she's sort of had everything, you know, BCG, gemcitabine, docetaxel, and there's been no recurrence of cancer for almost 3 years now based on all those regimes. But if cancer was to come back, let's say in a different location, not at the bladder neck, would a neobladder be an option, or the fact that she has had bladder cancer at the bladder neck before will completely rule her out?
No, not necessarily. If the bladder cancer at the bladder neck's been treated, and if on the further assessment of the bladder that's all clear, you could still do it. One of the things we know about with the female neobladders is that we need to get a reasonable amount of urethral length to put the neobladder onto for it to be continent. And so we want to have both a good surgical margin as well as an adequate length of urethra to put the new bladder onto. So it's important to assess that. And if I was in that situation, I would definitely re-biopsy that bladder neck before deciding, but it's not an absolute contraindication.
Great. There's another question we've had this asked before. Have there been any bladder transplants done, or has anyone been trying to do this?
Yeah, it's tissue engineering in bladder is something that a lot of people have looked at, because we don't have an alternative organ like the bladder. I mean, it's such a fabulous organ. Well, it's my organ, but, you know, it is such a unique construct, and so many people are looking at that tissue engineering at the moment. So far, there has been some work in animal laboratories with bladder transplantation, but I don't think there's ever been a successful transplant into a person as yet. But we're all waiting